Well, welcome everyone to Clinical Pearls from JCEM Case Reports. This is the second year we're holding this special forum. My name is Bill Young. I'm the editor-in-chief of the journal, and our co-chair is Dr. Adina Turku, who is the deputy editor for the journal. We have three presentations. They're going to be fairly short, about 7 minutes, followed by a Q&A with the author. And then we're going to invite up an expert on the topic to expound some pearls for you on that particular case. So we're going to start. Our first presenter is Dr. Lauren Doyle. She did her training at Beaumont Hospital, the RCSI in Dublin, Ireland. She basically just completed the equivalent of internal medicine residency in the US and is now moving on to her endocrine fellowship. The title of her paper is Clinical Utility of GnRH Analogues in Female Androgen Excess, highlighting diagnostic and therapeutic applications. Lauren?
Thanks very much, Dr. Young. So thanks very much for the invitation to present today. So I'm delighted to be here to talk everyone through our management experience of using GnRH analogues in diagnosing and treating female androgen excess. Is that it there? There we go. So I have no conflicts of interest to declare, but just to highlight that we are discussing an off-label use for triptorelin and other medications within the GnRH analog class. So before we dive into our cases, I think it's important to highlight the principle of GnRH analog testing. So this relies on the principle that ovarian-derived androgen excess will remain under the control of the HPG axis, but adrenal androgen excess will not. So following administration of a 3 milligram triptorelin or similar IM, we'll get initial pituitary receptor binding and a downstream upregulation of gonadal products. But at about 2 to 3 weeks, we'll see a resultant desensitization and downregulation of these receptors due to loss of pulsatility, and we'll see a 50% reduction in serum testosterone at day 28 following administration. So our first case, we had a 68-year-old woman who presented with a 3 to 4 year history of evolving facial hirsutism and alopecia. The click doesn't seem to be working on this for me. There, okay. Perfect, yeah, that's working better now. So she had some alarming features, including rapidly progressive vocal deepening and reported changes in the external genitalia in the immediate months prior to presentation. Her past medical history was largely insignificant, and she'd no previous reproductive concerns expressed. Her initial biochemistry was quite alarming, so we can see a massive elevation in her serum testosterone and quite inappropriately suppressed gonadotrophins for a postmenopausal woman. Interestingly, she also had elevations in her serum estradiol and elevations at both her hemoglobin and hematocrit, which have been reported in cases of virilization previously. So naturally, this woman underwent urgent radiological workup to try and ascertain where exactly the source of her androgen excess was. So she had normal adrenal imaging, but an ultrasound pelvis showed a large right ovarian hypoechoic mass. So while she was awaiting gynecology review, she underwent an adjunctive investigation in the form of a GnRH analog suppression test. And we can see the results of this here. So the benefit of doing this was to try and ascertain whether or not HPG axis regulation was maintained, which would be more reassuring for a benign etiology to her androgen excess. So here we can see full suppression of her serum testosterone at day 28, in addition to suppression of her androstenedione. So this lady was referred onwards to gynecology, had a benign ovarian steroid cell tumour identified following bilateral salpingo-oophorectomy, and most notably had full androgen suppression day 60 post-operatively. Our second case had a much more indolent presentation. So this was a 67-year-old woman who was referred with a 15-year history of hirsutism with some associated frontal hair thinning. Similarly, had no significant past medical history. Clinically, on exam, she did have evidence of an increased body mass, but no Cushingoid features or insulin resistance were evident. Her initial biochemistry, while abnormal, was not as significantly alarming as our first case, but we did see a testosterone of 2.5 on her initial biochemistry and an estradiol of 130. In terms of ascertaining where exactly this was coming from, she had a normal overnight dexamethasone suppression test, and an incidental left-sided adrenal myolipoma was identified on CT imaging, and she had normal transvaginal ultrasound with no evidence of any ovarian pathology. Given her overall biochemical pattern, her indolent clinical history, and normal imaging, it was felt that this woman most likely had a benign ovarian source for her androgen excess, and most likely in keeping with an ovarian hyperthyrotoxicosis. So she had a 50% reduction in her serum testosterone following 28 days after a GnRH analog suppression test, which would be indicative of a confirmatory test. Given the chronicity of her symptoms, the absence of any features of virilization, it was felt that she most likely had a benign ovarian pathology, most likely an ovarian hyperthyrotoxicosis. Given her initial symptomatic relief following administration of the GnRH analog, she declined further referral for surgical intervention, instead opting to continue with regular triptorelin therapy, which was ultimately transitioned to a long-acting depot preparation due to successful symptom suppression. Our final case discusses a benign use, or a premenopausal case of a 25-year-old woman referred with significant hirsutism and secondary amenorrhea. Her past medical history was significant for juvenile dermatomyositis and an overall adverse metabolic phenotype as indicated by her steroid-induced hyperglycemia previously and hypertension and obstructive sleep apnea. Clinically, she had evidence of a partial lipodystrophy with relative truncal sparing and stigmata of severe insulin resistance. Her initial biochemistry showed an elevated LH to FSH ratio and then very significant elevations in her serum testosterone and androstenedione. She also had massive hyperinsulinemia. So the working diagnosis here was a severe insulin resistance syndrome, most likely an acquired partial lipodystrophy in the setting of her juvenile dermatomyositis. She had normal imaging overall with no source identified for androgen excess. So she underwent a 3 milligram triptorelin administration to try and ascertain whether this was ovarian or adrenal in origin. And she had confirmatory testing here with full suppression of her testosterone following 28 days. She also had very significant symptom resolution. As a result of this, she opted to trial regular GnRH analog therapy with add-back sequential combined HRT for bone and vasomotor symptom alleviation. Unfortunately, this had to be temporarily discontinued following an ischemic stroke. However, this was felt more than likely to be in the setting of her systemic vascular resistance and unrelated to her GnRH analog therapy. Given that she's no desire for future fertility, she's opted for a gynecology referral for an elective bilateral salpingoophorectomy. So in terms of take-home messages, we propose that the GnRH analogues would be potential useful adjuncts in the diagnosis of suspected ovarian androgen excess, with the potential to reduce reliance on any invasive procedures in the correct context. Therapeutically, they offer a potential non-operative management option for postmenopausal women, again with clear benign sources for androgen excess, who wish to avoid surgery, or indeed for premenopausal, again with clear benign sources, who with very significant symptoms, who wish to have a fertility-sparing alternative. It's very careful that careful case selection is undertaken and that features of virilization or indicators of malignancy are not overlooked. Thank you.
Thank you, Lauren, for that presentation. You kept right on time. For those who have questions or comments for Lauren, we have a microphone in the aisle over here. Just come to the microphone, introduce yourself, and ask your question.
In the meantime, Lauren, I would like to ask you a question. In your first case, where you had an ovarian tumor, you decided to use this test to differentiate between a potential malignant versus benign cause. Have you used PET imaging?
No, so we hadn't used PET imaging in this case. Another kind of potential imaging that may have been useful in terms of identifying a potential tumour versus an ovarian hyperthyrotoxicosis maybe would have been MRI. They seem to have reasonable sensitivity, but we didn't have PET imaging available in our institution for that type of indication.
Interesting.
So I want to.
Yes.
Some adrenal tumors have LH receptors. Do you have any experience from your review of the literature of how they might respond to this analog?
An interesting question. I have no personal experience around that particular indication, but I know particularly in the cases of the insulin resistance syndromes with our partial lipodystrophy, that they can get some stimulation by the excess insulin as well to give them adrenal androgen production, but I wouldn't have any direct experience in terms of LH and adrenal androgens.
Richie Quinton, Newcastle. Mick said to come and say hi. Okay. I can answer that question. Yes, if an adrenal adenoma expressing the LHCG receptor, yeah, they shut down perfectly with a GnRH analog treatment. But my question was, I'll go next question.
Peter Liu, Los Angeles. So in your third case, the person had sleep apnea, and there's evidence that if you reverse the hyperandrogenism, the sleep apnea can actually improve. Did that actually happen in that case?
So she didn't. We've only, I think, had maybe 12 months since we've commenced therapy, and given the kind of interruption, particularly around the time of her, the concern around the stroke, we haven't had a sustained period of time long enough to really ascertain whether or not we got improvement.
The question I was going to really ask before I bulldoze Pete out of the way, sorry, was it's a great treatment, but in terms of diagnostics, what does it add above nothing in the adrenals and low DHEAS?
I suppose in terms of what it adds, I think in our experience, in terms of reassuring imaging, it gave us kind of some additional reassurance that there may have been a purely ovarian benign source going on here rather than anything adrenal.
Al Rogel, Charlottesville, Virginia. Old wrestler, so those are good hands. Especially with Adina on the as chair. The issue that you're trying to do is to distinguish between ovarian and adrenal. So is there a place for measuring oxotestosterone or oxo-DHT?
I think down the line that would be something that we'd like to include, but in terms of assay availability and resource allocation, that can be quite challenging, particularly in some of the contexts that we're working within. So hopefully down the line, when we have greater availability of those type of diagnostics, it would be great to include them. But in terms of the resources that we have at our disposal, this could be an additional benefit in that context.
Thank you. Any words of wisdom, Adina?
So in the US, LabCorp at least, and I think maybe Quest is incorporating these assays, but I know LabCorp offers 11-ketotestosterone.
Great. Lauren, thank you very much. Now I'd like to invite up our expert on this topic, Dr. Frances Hayes from Mass General at Harvard, right here in Boston. Frances?
Thank you very much, Bill, and congrats to Lauren for an excellent presentation. So the question here, as Dr. Quinton raised, is what is the utility of GnRH analogues as both a therapeutic and diagnostic modality when you're faced with that patient who has significant hyperandrogenism? So the first question is, as Al asked, is the excess androgen coming from the ovary or is it coming from the adrenal? As Lauren mentioned, the hormone profile, the baseline hormone profile can be helpful in that if there's a predominant increase in testosterone over and above androstenedione or DHEA, that favors an ovarian source and can be confirmed if there is significant suppression. The question then is whether you need to do this test on everybody that you see with significant hyperandrogenism. And I think that really depends on the clinical situation. If you have a normal adrenal CT, you have effectively excluded a functioning either benign or malignant adrenal nodule. Now, in one of Lauren's patients, there was an adrenal myelolipoma, not traditionally considered to be functioning, but if you did have a lesion in the adrenals, you weren't sure if it was an incidentaloma or not, potentially a GnRH analog suppression test could be useful, or you might consider adrenal vein sampling. There's a poster from the Mayo Clinic group on Monday, though, that shows that in a study of 22 women where they did combined ovarian and adrenal ovarian sampling, there was no evidence of an adrenal source in those patients. So if the adrenal imaging is normal, then you could focus on the ovary. And here the question is there bilateral or unilateral adrenal or androgen production? And if it's unilateral, which side is it coming from? And here, unfortunately, a GnRH analog is not particularly helpful. It doesn't help you to lateralize, and it really doesn't distinguish between a benign source like ovarian hyperthyrotoxicosis and a tumor sources, because there's overlap in the degrees of suppression. I would also add, as a clinical pearl, beware of a report that says normal ovaries in a postmenopausal woman if it doesn't give you an actual volume, because the ovaries do decrease significantly with age. The average volume is about 2.2 mLs. So an ovarian volume of 5 mLs in a postmenopausal woman could certainly raise suspicion for ovarian hyperthyrotoxicosis. So the real conundrum, I think, is the premenopausal woman, where there's a short history, there's concern for a tumor, but the ovarian imaging is unrevealing. And this, I think, is the situation where ovarian vein sampling, if it's available in your institution, can be very helpful. So my feeling is that the GnRH analogues do have a role, but more from a therapeutic perspective as opposed to diagnostic. And Lauren showed an excellent response in her premenopausal patient pending bilateral oophorectomy and in the postmenopausal patient who declined definitive surgery. I don't know if we have time for questions.
Questions or comments for Dr. Hayes? Okay, Francis, thank you very much for sharing those insights.
Our next case presenter is Dr. Lauren Wolfish, who comes from McGill University in Montreal, Canada. She will be talking about a case of Molar pregnancy-induced hyperthyroidism and the importance of early recognition and timely preoperative management. Laura?
Thank you. So I'm super excited to be here and to walk you through this case of this rare presentation that we had at our hospital. So our patient, she was a 32-year-old female, first time pregnant at 10 weeks gestation, previously healthy, did not take any medications, and she presented to a community hospital with a 2-week history of bloating, abdominal pain, and nausea. On further history, there was no bleeding, no symptoms of hyper or hypothyroidism, which was thoroughly questioned, and no family history of thyroid disorders either. So on exam, her vitals were completely stable. She wasn't tachycardic. Her thyroid was completely normal as well. She had no tremor, nothing else on her extremities. She did have an abdomen that appeared pregnant, but the rest of her exam was unremarkable. So on investigations, her beta HCG was over 420 million. And yes, that's the right amount of zeros. And so for a patient who is about 10 weeks gestation, it should be about 60,000, her beta HCG. So that was very surprisingly high. And so this was her pelvic ultrasound here. And so you could see there's some kind of mass. But for people who aren't used to interpreting pelvic ultrasounds, it was reported as a 10 centimeter molar pregnancy invading to the posterior myometrium. So her thyroid profile, her TSH was not detectable, and her T4 was 43. And at this time, there was no TRAB or T3 that was sent or available just yet. So this whole clinical picture at this moment is concerning for a biochemical hyperthyroidism with no clinical evidence of thyrotoxicosis. But it was concerning for an impending thyroid storm. So she was transferred to our quaternary care center, and right away, many services were involved. So of course, OB, endo, anesthesia, and ICU. So all of these services sat down together, had a discussion, and so she was planned for an urgent laparoscopy with uterine evacuation. So essentially, they took a peek into her belly and also did a D&C, so through the vaginal route. And so, of course, with the laparoscopic surgery, she needed general anesthesia to go through this. And there was a post-operative ICU plan for the patient to be transferred there after her surgery. So from an endo point of view, she was started on hydrocortisone, PTU, and beta blockers were on standby. Her vitals were stable at this moment. She had her surgery. It was non-complicated. She was transferred to the ICU, clinically stable, and her medications were continued there while she was closely monitored. After 24 hours, her PTU was reduced to 200 twice daily, and her steroids were stopped. And given the very, very high beta-HCG on presentation, the gynecology service gave her a prophylactic dose of chemo just to ensure that nothing else was going on or to happen. Her TRAB came back negative, and her final pathology was a complete hydatiform mole. So as she was stable, she was able to go home on day 3 post-op. She continued her PTU, and she had close follow-up arranged with both gynae and endo. So her follow-up. So here is a graph of her thyroid hormones. I'll just orient us a little bit. So, oh, you don't see my cursor. So anyways, you see her day before surgery. On the x-axis 0, that's her day of her surgery. Oh. Sorry, I don't know how to use this. Oops. Sorry. Oh, there it is. Maybe I'm better off not using it. And anyways, so her TSH here, so you could see it was undetectable before her surgery, at her surgery, and then around day 13, it started to rise. You could see her in orange, her T4, so it started to come down very nicely after her surgery. And we got her T3, the first one was on the day of her OR, so it was also a little elevated and then came down. So then at 2 weeks post-op, when she came in for her follow-up with endo, her free T4 had actually been hypothyroid. She was clinically totally normal, but at that point her PTU was stopped, and she might have also had some symptoms of a rash, so she was stopped for both reasons. So her beta-HCG, on the other hand, so this graph, just to orient you as well, for scale, the 400 million is not on here. It comes down, but the y-axis is like an increment of 20,000. So it did come down very nicely, but you could see starting at day 19, it kind of took a turn and started to increase. So at this point, gynecology did a repeat dilatation and curettage. They made sure there was no evidence of metastatic disease on imaging, and they gave her methotrexate as chemotherapy. And throughout all this, her thyroid was not a problem. So you could see here on this graph the trend of her beta-HCG. It came down quite nicely after the second treatment. So some learning points to take out of this. So it's essential to recognize the link between gestational trophoblastic disease and thyrotoxicosis, and it's important to anticipate this early because thyrotoxicosis can happen, especially undergoing surgery and general anesthesia could trigger a thyroid storm. And obviously severe consequences can occur if this is left untreated. So a multidisciplinary approach, especially when there's no guidelines to treat such a case, is very important to prevent poor outcomes and make sure the safety of the patient. So thank you.
If you have questions about this case, you can come to the microphone and ask your questions.
I think this session is cursed. I just about tripped over somebody. Carol Weisham from Spokane, Washington. Nice presentation. I was just curious as to the rationale of continuing the PTU after the evacuation of the mole.
Mm-hmm. So we got this question when we published the paper as well. It was just done out of preventative measures, just no real reason that I could give you.
Linking into this question, I would like to ask you, as a non-OBGYN person, how long are you supposed to follow the beta-HCG? I saw you followed for at least by 19 days. It's returned at higher levels?
So they were following it until it normalized. So it still hadn't normalized.
That's
On the
right.
graph, it was still like 10,000. Even though it came down significantly, it kind of looked like it was normal, but it was still not yet at 0.
Is this a common thing for a molar pregnancy to recur after DNC for or some residual tissue to be left, so requiring a second DNC, like in this case?
I don't know the exact statistics, but I would think it's something that's rare.
Got it. We're endocrinologists. It's okay. Thank you. So if there are no other questions right now, I'd like to invite our expert, another local, again from Boston, Dr. Elizabeth Pierce from Boston University School of Medicine.
So thank you, Laurel. Interesting case, beautifully presented. And I think this raises a few issues that are sort of helpful to think about that we may see in more common contexts than the one you saw it in. So anytime we see HCG-mediated hyperthyroidism, typically patients don't have a lot of hyperthyroid symptoms, and that was true in the patient that you presented. And that's probably because unlike Graves' disease, which is going to be the other common cause of hyperthyroidism in a woman of reproductive age, the primary sort of clinical sign in HCG-mediated hyperthyroidism is nausea and vomiting, because HCG is what mediates the nausea in pregnancy. And so women present with that as the predominant symptom, and therefore you get kind of an overlay of non-thyroidal illness. So when you look at the thyroid function tests, you see relatively lower T3s than you might expect, which is effectively sort of the body's response to starvation. So she's not very thyrotoxic. And that's what I would expect. We see this more frequently in women, not with molar pregnancy, but with gestational transient thyrotoxicosis in the early pregnancy, when HCG is typically not as high as you would see in a molar pregnancy like this, but still either very elevated, as in a twin or triplet gestation, or maybe women with somehow more bioactive HCG. We can see patients who present with thyrotoxicosis, and the challenge is often to distinguish that from Graves' disease in early gestation. So the TSH receptor stimulating antibody, which you did eventually get in this patient, can be very helpful in that context. Presence or absence of nausea, presence or absence of thyrotoxic symptoms, all are really helpful in making that distinction. And then the challenge in this patient was to prepare her for surgery, needing general anesthesia, at a time when she was really pretty profoundly hyperthyroid. You don't want to delay a surgery for a molar pregnancy. Women can get severe bleeding, they can get preeclampsia. So there was some urgency to getting this done, and you didn't have the luxury of waiting for her antithyroid drug to bring the thyroid hormone levels down. So we have to think about rapid surgical preparation, again, probably more commonly in different settings. Often it's the patient with severe Graves' disease who can't tolerate antithyroid drug, where we need to get them to the OR and get them through the surgery safely, and we always worry about the anesthesia-inducing thyroid storm. So we've got a bunch of things in the toolkit that we can use. Some of them were used here. In this patient, she could get antithyroid drug. PTU was selected over methimazole because of the theoretic advantage, I think, of blocking T4 to T3 conversion as well as decreasing thyroid hormone synthesis. I'm not honestly sure how much difference that makes in most clinical contexts, but it's probably the right textbook answer and the way to go. She also got glucocorticoid at high doses because that will, as a potent inhibitor of T4 to T3 conversion again, and the whole goal here is to try and knock down those circulating T3 levels as quickly as possible before the operation. She got IV hydrocortisone. BID 1 milligram dexamethasone actually works just fine in preparing patients for rapid surgery when they're thyrotoxic. Other things she could have considered, beta blocker, particularly propranolol, which again decreases T4 to T3 conversion. Was considered in this case but not felt to be needed, and she did just fine with the surgery without it. And then other possibilities could have considered would have been high-dose iodine, Lugol's or SSKI, to induce the acute Wolff-Chaikoff effect and sort of rapidly decrease thyroid hormone synthesis. And could have considered cholestyramine, which will decrease circulating thyroid hormone by interrupting the enterohepatic circulation. And when all else fails, one can consider plasmapheresis. But happily, this patient did fine with glucocorticoid and antithyroid drug alone. So with that, I think we've maybe got a few minutes for questions if there are any. Oh, and another comment about why continue the PTU after the pregnancy. T4 has a long half-life. But the PTU, obviously, as I said, I don't think it's doing that much to decrease T4 to T3 circulation, so I'm not sure that there would have been a huge benefit.
Thank you so much. We're actually right on time, but if anybody has one or two extra questions, we can take them. If not, we thank you very much.
Okay, our next and last presenter is Dr. Salman Bhatt, who recently completed his endocrine fellowship at Johns Hopkins University in Baltimore, Maryland. The title of his paper is Type B Insulin Resistance Syndrome, a rare cause of hypoglycemia. Salman?
Good afternoon, everyone. Thank you for the opportunity, and thank you for everyone for coming. So today, we're going to present an interesting case of hypoglycemia that we saw in the inpatient consult service, who was diagnosed to be from type B insulin resistance syndrome. So we have this 59-year-old black female with a history of SLE and insulin-dependent diabetes mellitus, who presented with altered mental status. She was found to have a blood glucose of fingerstick glucose of 30, which was resolved with administration of IV dextrose. This was the first known episode of hypoglycemia. She also reported a 100-pound weight loss and no recent changes in her dietary patterns or insulin dosing. Her A1C was 7.7% at the time of admission. This was the medication list on admission. As you can see, she was on both on long-acting and short-acting insulin. None of the doses were changed, and the other medication lists did not have any medications with a high evidence of hypoglycemia risk. Subsequently, on physical examination, the pertinent positives were a BMI of 29.3. She also had gingival hyperplasia with many of her teeth missing, along with axillary acanthosis nigricans and axillary adenopathy. She had no significant evidence of facial hair or any other hirsutism. As you can see on the left side, she has axillary acanthosis nigricans, but none in the nape of the neck. Subsequently, during the hospital course, our initial thought was exogenous insulin-mediated hypoglycemia. Insulin use was stopped. However, patient continued to develop multiple overnight hypoglycemic episodes, which were confirmed both by fingerstick testing as well as by blood glucose checks. Subsequently, she underwent a 72-hour fasting test to make sure all the labs were appropriately obtained. As we can see here, we did the 72-hour fasting test, and 12 hours into fasting, she had a blood glucose of 44 with a significantly elevated insulin and pro-insulin level, and a detectable inappropriately detectable C-peptide. We also did an oral hypoglycemic agent panel and an insulin autoantibody testing, both of which were negative. Other lab evaluation also showed serum triglycerides of 71 and high, which was normal, and an adiponectin of 28, which was high normal. In a typical type 2 diabetic, we would have expected a significantly higher triglyceride level and a low adiponectin level. Her adrenal and thyroid function was normal. SLE antibody titers were elevated. Subsequently, she underwent imaging of her abdomen. Her CT abdomen pelvis showed widespread lymphadenopathy. We also obtained an MRCP, which showed an 11 millimeter cystic lesion in the pancreas with T2 hypointensity, which was more consistent with an intrapapillary mucinous neoplasm. We also did core needle biopsy of the lymphadenopathy, which showed a reactive lymphadenopathy. At this point, we had a wide differential diagnosis. The initial one was insulinoma, along with these other ones, most of which were ruled out with previous biochemical testing. At this point, because of the characteristics of the tumor on the MRCP, it did not meet insulinoma. It was a cystic lesion, which was less likely to be an insulinoma, and this patient had multiple other characteristics which are seen in this rare case of type B insulin resistance syndrome, which included her history of SLE along with being black. Subsequently, she underwent further testing. Her blood was sent to Dr. Schomburg's lab in Germany, who has a validated assay for testing this disease. and the testing was strongly positive for anti-insulin receptor antibodies, which was diagnostic of type B insulin resistance syndrome. As you can see here, there was a negative control in the lab, and then there was a positive control with a binding index of 38. A binding index of greater than 10 is highly positive for type B insulin resistance syndrome. And as you can see in our patient, it was 248, which was significantly positive. Our patient was treated by cessation of insulin therapy. We provided dietary modifications with cornstarch at night and continued the use of CGM. A rheumatology service was also consulted, and she was continued on the hydroxychloroquine along with addition of belimumab. 3 months after index admission, the patient was not on any diabetic therapy. Her A1C was 5.4%. And she continued to have overnight mild hypoglycemia. As you can see in the CGM tracing, there was around 13.8% hypoglycemia, along with a 1.6% very low hypoglycemia, all of which was manageable for the patient, and the graph shows this overnight hypoglycemia continuing to occur. So the learning points in our case, so type B insulin resistance syndrome is primarily presents with severe insulin resistance and severe diabetes mellitus requiring a very high dose of insulin, and very rarely can cause a hyperinsulinemic hypoglycemia. This happens in around 20 to 40% of the patients at some point in their clinical history. Diagnostic pointers towards type B insulin resistance syndrome include Black women with a history of autoimmune disease. Biochemical pointers include a normal triglyceride level and a high normal to high adiponectin levels. In a typical type 2 diabetic patient with metabolic syndrome, we would expect a normal or an elevated triglyceride level or a high adiponectin or a low adiponectin level. Anti-insulin receptor antibodies are diagnostic of TB-IRS, and assays are not frequently available. This was sent to Germany. There are other places we can send to, and I think there was a recent NIH paper which also discussed an assay, new assay formed, which could be tested in the US. And typically in TB-IRS, we see elevated serum insulin levels and undetectable C-peptide levels. Our patient did have detectable C-peptide levels. The source of this discordance is the differing methods of clearance of insulin and C-peptide. The insulin clearance is driven by the receptor-mediated endocytosis, whereas C-peptide is not. So in addition, one point I want to mention is the treatment protocol. So NIH has a treatment protocol for this disease, which consists of multiple immunosuppressant medications. This was not followed in this patient because she had good response to dietary modifications, and we did not go ahead with that. Moreover, this treatment protocol was mostly tested in hyperglycemic patients. Thank you.
Questions, comments for Salman? I have one question. I'm an adrenal guy. I guess I don't understand, why is insulin high if you have an antibody triggering the receptor? Shouldn't insulin levels be low?
So the body compensates. So there is significant insulin resistance in the body. So the pancreas just continues to produce insulin. It's not getting, the insulin does not move away because it depends on receptor-mediated endocytosis, which is blocked by the high receptor levels. The receptors, the antibodies are binding to the receptor and preventing this breakdown of insulin. That's the reason.
Got it. Thank you. Steve?
So is the black race predisposition related to the predisposition to lupus, or is there something else about the black race?
So good question. We don't know much about what is causing that. As you rightly said, autoimmune disease is, seen more, SLE is seen more in African Americans. That's a pretty rare disease, so we really don't have much data. Most of the data comes from, large case studies, but we really haven't had that connection. But that's a good question.
Hi, Jack Snitzer at Tuttle Health. I'm lucky enough to work with Dr. Bott now. Why did this happen now as opposed to, or what triggered it as opposed to a year or two earlier?
That's a good question also. So The presence of hypoglycemia or onset of hypoglycemia can be very variable. It can be dependent on the antibody titer. So high antibody titers in this disease are linked with hyperglycemia. Low antibody titers are linked with hypoglycemia. So it could be very variable that her disease was going into remission. A lot of patients, around 20 to 30% of these patients do go into remission. So that could have been a possible cause that she was slowly coming down. Her antibody titers were coming down, and she developed this now. Thank you.
Last question.
When there is insulin resistance, generally triglyceride level should be high. Here the triglyceride level is normal.
So that's a very good question, and I did read about it. So the effect of the insulin receptor antibodies is dependent on where they act. So in this case, they really don't have much effect on the liver. So it's not a post-receptor defect. It's a pre-receptor defect, or defect at the receptor itself, and this does not affect the receptors in the liver as much, and that is where the triglycerides arise from.
Try to explain by the differential insulin resistance on the various organs.
Compared to lipodystrophy, where you have a more generalized post-receptor defect.
Thank you.
Salman, thank you very much.
Thank you.
So our expert discussant is Dr. David D'Alessio at Duke University School of Medicine, Durham, North Carolina. David?
Thanks, Bill, and thanks very much for a really nice case, Dr. Bott. Being called an expert here is a little euphemistic, since I've seen one case in my life, and it was the year before I started my endocrine fellowship. I was at Temple University, where Gunther Boden was head of metabolism, and he was trying to convince me to go into endocrinology. So he brought me to the research unit and showed me how to do a glucose clamp, and the patient, he didn't tell me, had type B insulin resistance, and he was showing me that you could give virtually infinite amounts of insulin to this patient, and the blood sugar wouldn't move. It did make me curious, and I did go into endocrinology. I'm a little nervous that somebody in the audience has seen two cases, and that they may demolish my credibility. This is actually a really interesting condition historically. The first cases were described by the NIH group in the early 70s. And it really was led to a lot of fundamental discoveries about the insulin receptor, about insulin signaling, so that for a cause of hypoglycemia that's very rare, it had a big impact scientifically. And if you look at the people who reported these cases and did the evaluations, Flyer, Kahn, Taylor, these were all the people that then went out and worked on insulin resistance. And the 80s were a decade where insulin resistance came to the fore as a pathogenic mechanism and as essential in type 2 diabetes. And it's this syndrome, I think, that drove a lot of the research, put a lot of the tools in the hands of people to study the insulin receptor. This particular patient is right out of central casting from the cohort that the NIH assembled. They have 40-some patients. And then if you look at the rest of the literature, there's less than 100 case reports of this. So I guess my one case may not be that puny. The patients that the NIH seen were disproportionately African American, disproportionately female, and had lupus about half the time or some other autoimmune disease most of the time. Now, that being said, if you look at reports from the rest of the world, in Japan, again, they put together a case series that was mostly male. So I think making too many demographic or predisposing conclusions is probably premature. And I would say again that the big problem with this syndrome is that we don't have a great detection mechanism, right? The NIH people came up with an immunoprecipitation assay that's very similar to what we use now clinically in Graves' disease, a TRAB mechanism, where you take a recombinant protein and you use that to capture antibodies from the serum. That's never been standardized and put into clinical practice. So it ends up being a really difficult diagnosis to make. And I was really impressed that Dr. Bott and his colleagues were able to sort through this and come to this diagnosis, because it almost seemed like a made-up case with one red herring after another looking you in the face. I think a commercially available assay would be useful. You know, as endocrinologists, when we see a case of bona fide hypoglycemia, somebody that's not taking medications, insulinoma is at the top of the list. And you can say, well, the CT didn't show insulinoma. That happens about 20 or 30% of the time. So that, you know, the probabilities were in this case was that even with a negative CT, insulinoma might have been more common than type B insulin resistance, although we don't really know what the epidemiology of the latter is. So, you know, to me, the things that would make me think about something like an autoimmune mechanism would be the really high levels of insulin and C-peptide. Oftentimes what we see are kind of inappropriately normal levels of insulin and C-peptide in insulinoma. And in these cases where you have essentially a circulating sink of antibodies that are holding the insulin, the levels can be really high. Again, just to talk about the pathogenesis again, the antibodies are in high titer, whether they're true agonists or whether they just mediate clearance of the receptor from the membrane. When they bind to the receptor, the clearance is increased. So you actually have a downregulation of insulin receptors, and that may be the insulin resistance. They're partial agonists, and the partial agonism effect seems to be present, as Dr. Bott says, at low titers. So it's a very confusing thing. But again, the analogy to Graves' disease, where you have antibodies to the TSH receptor that do different things, is not far-fetched. Let me just finish by thanking Bill and Adina not only for inviting me to this really interesting session, but for forwarding this journal. Case reports, you know, oftentimes get short shrift, but if you work in a setting where you get a lot of referrals, to have good case reports and a good source for them is essential. So I thank you both.
David. Oh, we have one question from Al, but it has to be short because we're...
Well, I am short, so it's easy.
Yeah.
Dave, I'm as expert as you are. I have a series of one. I was trained at the NIH with Ron, in the group with Ron Kahn. I sat with a patient with this condition. I gave her, she started out with a blood sugar of 300. I gave her 50,000 units of insulin sitting by the bedside. I finished, her blood sugar was still 300.
Yeah.
It scared the hell out of me the whole 6 hours I was there.
Well, when I saw my case, I didn't know better. 10,000 units just seemed like what you gave someone.
Well, I want to thank David for the plug for the journal. Adina and I encourage you all to consider submitting your interesting, challenging cases to JCEM case reports. With that, we conclude our session. Thank you all for coming.